finally, how can we prevent our patient getting cold? So we want to warm our patient up, and usually pretty aggressively. So we can either reduce heat loss or we can actively apply heat to the patient. So we can warm up the room. If you think about your average orthopedic theatre, they're very cold environments, and even the anaesthetist is cold. So warming up the theatre to a safe level for operating, but not having it too cold, that's the biggest way to do it, because that reduces your radiation heat loss, which is the biggest component. Wrapping the patient up in adequate clothing is a really good thing. Now, obviously you need the patient exposed for surgery, but beforehand, having the patient nice and warm before you anaesthetize them makes a big difference, because if we look back at our redistribution phase of our heat loss graph, if the patient has got a warm core but cold peripheries, then it makes sense that this redistribution is going to be huge because they've got a lot of cold periphery to warm up. But if they're nice and warm when they come in, and there's not much difference between their core and their periphery, then they're not going to have such a rapid loss of heat from the core to the periphery. So it's a really easy and really effective way to reduce that rapid drop in core temperature at the start of your anesthesia. Next up, we have things like bear huggers or forced air warmers, and what these do, they reduce convective heat loss. So they provide a warm cushion of air around the patient. They apply heat to the patient, but what they're mostly doing is preventing that convective heat loss from occurring. And we have fluid warmers, which warm up IV fluid. Now the reality is, if you slowly drip warmed fluid into the patient and it travels through the giving set to the cannula, by the time it gets there it's probably cooled down to room temperature. But if you're resuscitating with rapid large volumes of fluid, it makes a big difference to have that fluid warmed, because it'll still be warm when it gets to the patient. This generally does not warm the patient up, it just reduces conductive heat loss through your IV fluid. Next, we have the HME filter. This is your heat and moisture exchange filter. In essence, it's a wet sponge in the breathing system, and as the patient exhales, the sponge absorbs water and collects heat from the exhaled gases, and then when they re-inhale a new breath of air, that's cold air coming from the machine picks up the moisture and the warmth from that sponge, and it reduces the amount of respiratory heat loss. Just be aware, they take about 20 minutes of breathing before they're actually doing anything substantial. So for a 10-minute case, it's not going to do much, but they're very, very important on intensive care, prolonged ventilation. Then we've got simple things like heated mattresses, Inditherm electric blankets, that kind of thing. And then if you're trying to actively warm a patient up, such as someone who's come in extremely hypothermic, you can do more invasive things like body cavity lavage. So if you've got a patient with an open abdomen, you can flood their abdomen with warm saline and warm them up that way. And then you've got things like ECMO or bypass, where you can very easily control the blood's temperature and very rapidly infuse it. But those are specialist techniques you will only really use in certain circumstances.